He moved to Hendersonville, North Carolina, and has practiced biological dentistry there since joining the IAOMT. Would you please welcome Dr. Matt Young?
So my topic today is time economics in a biological dental practice. I've talked a lot about digital radiography with some of my colleagues at IAOMT and treatment planning on the computer and various things. And a lot of people said, boy, it would be nice if you could put all this together into some type of presentation to help show how you might do things differently in your office than you might have done 5 years ago. So that's kind of the crux of what this is all about. So the main question we ask ourselves every day when we're coming to work is, why do we do what we do? So I thought I'd show some pictures of the first IAOMT International Fishing Tournament we had down in Naples last year. We tried to recruit some Americans and some Canadians to fish, but unfortunately the Canadians were all busy doing the AV stuff. Dr. Wilson was a part of it too, and since he's from Minnesota, he's like half Canadian, half American anyway. So the first fish he caught was for the Canadians, the second fish was for the Americans, and so on and so on. And then Dr. Nestor Shafka, unfortunately the Canadians caught a lot more fish than the Americans did. I'd like to just talk a little bit about what time economics is. We observe and study everything we do. We refine and polish everything we do in order to maximize our productivity, our restorative quality for our patients, their comfort and their satisfaction with coming to us as biology dentists compared to just a traditional type dentist, and therefore the profits and the distributions that we give to our staff. I have a bonus system set up in my office, and if you want to ask me later on, I can tell you how we distribute bonuses every month. And then our organizational levels we want to maximize. What we want to minimize is confusion and disorder in the office, patient complaints. Of course, nobody has those, right, but me. Remakes, miscommunication, wasted time, and employee tensions. So to me, in the concept of time economics, there's two main broad concepts here. The first is the administration part of it, the diagnostic technology that occurs when the new patient comes into your office, and then the clinical time economics. And these two overlap quite a bit during the patient's experience with us in the office. We always begin by analyzing the new patient experience, which starts at the initial phone call to the moment they walk out the door. And it's really important, in my office at least. I have about 4 pages of legal-sized paper that has the whole new patient flow chart. And every time we hire a new employee, we go over that flow chart with everybody, and we rehearse it so that everybody's on the same page in the office as far as what happens from beginning to end. And to a certain degree, the way our office is set up and the way I think any office should be set up, it's different now with HIPAA. You really should have a private area to discuss finances with the patient. If you look at all the restaurant statistics, the restaurants that have the cleanest restrooms always have the biggest amount of volume of work and food that they sell every month. And the reason why is when the wife goes into the restroom, if it's nice and clean, they're going to come back. If your wife goes in the restroom and it's dirty and there's stuff all piled around, they're probably not going to come back. So I keep a close eye on my restroom every day because I know if it's in good shape that the patient's going to get the perception that your office is really clean. Our new patients, we have this in the front of their chart for every new patient, and it's just like an airline checklist. If you ask Dave Kennedy, he's going to tell you, I've got this checklist before I take off in my airplane, and I'm going to go down through that checklist religiously every time I take off. And it's very easy to forget to do your perio exam or forget to take study models or take your digital x-rays. So we have this checklist with little bullet points, and every single new patient that comes in our office, we go through this complete checklist. But to me, it's important to get the diagnostic part done first. We then give the patient the opportunity to go through Meridian stress analysis, and I have 2 or 3 gals in my area that do this for me. They have the whole broad gamut of all the dental materials that I use in their computer. The patient then gets tested along their biomeridians. Then I give them the opportunity to go see John Wilson and Eileen Wright up at Great Smokies. I'm very honored to have them as a part of our team. And we tell the patients, we're getting 66% of your mercury out by getting your amalgam fillings out. If you want to get it out of your tissues, you've got to go see Dr. Wilson or Dr. Wright to get the rest of it out. So we go down through this checklist with every single patient. To me, I think we should really talk with everyone about the mercury issues. And the way I open that up is, do you have any questions about the mercury silver fillings in your mouth? And then usually if they don't know anything, they'll say, oh, it has mercury in it? And I'm like, well, yeah, it's 50% by weight of mercury. And so therefore, that usually opens up a conversation. And to me, once that door is open, then I discuss with them, well, my most sensitive mercury patients are the folks who are the canary in the coal mine, because they're the ones getting the sickest from the mercury. How much do we know it's affecting your body? You might not be having symptoms right now, but what happens 10 years down the road when the autoimmune diseases kick in and what happens if you have problems with your kidneys or your liver later on. There's no way you can really determine what's going to happen in the future. So then you have to kind of come up with some analogies, some ways to discuss with patients about how the mercury is affecting their system. So I talked to them about the liver, how the liver is the major detoxifier. And inside that liver is a little revolving door. And the mercury is all the bad guys trying to get out of the liver. Some people have a revolving door that's moving real slow and creaky like this, so they're very poor excretors. Other people have revolving doors that spin pretty fast, so they're pretty fast excretors. And Dr. Dave's going to help me out here in a second. We have a little demonstration about SpongeBob. We basically talked to him about what the environmental dose is all about, how much their absorbed dose is, what their body absorbs, what their excretory rate is, and then the difference between the two is the body burden, and then taking into account a couple of the important limiting factors that we've been discussing. So this is my little way of kind of showing patients how we talk to them about mercury. So I got this, I want you to squirt from this side because I'm left-handed. Okay. So I got this ink from Staples, and it sticks to everything that you spray on it, Dave. And so this is SpongeBob, my patient. I mixed in a little bit of ink with some water here. And at this moment, Bob is a pretty poor excretor, and Dave's going to spray some ink on him, and he's going to represent the mercury fillings absorbing back into his body again. So right now, Bob's a pretty poor excretor. He's not excreting very fast. But if we give him some DMPS or some EDTA from John, then he's going to begin to excrete a little bit faster. Okay? And now, so the difference between his environmental dose and his absorbed dose and his excretory rate is demonstrated by the body burden. Okay? Let me get a little bit more here. Now, we all have patients. We all have patients that come in the office with these little hair samples, and they say, oh, I got a little hair sample here, and I got my hair sample tested, so I really got to get my mercury out right away. And I'm like, well, yeah, but their hair sample doesn't have anything to do with how much is in the sponge. So a lot of patients are like a yellow belt in karate. They know just enough to get themselves in trouble. So it's up to us to kind of educate them and explain to them, you know, exactly how much is in their body, which can only be determined by a physician, someone who really knows a lot about chelation. So I wanted to kind of thank Dave for his help today, and especially because I gave him so much hard time because Carolina whipped the Canadians' butts. Well, thanks, Dave. Again, when we get ready to take mercury out, this is a handout that I give to patients demonstrating the biology technique, the equipment that we wear, the air filter, and the water separator. And then whenever we send out our new patient packets, we always show them, this is what we expect from you, and this is what you can expect from us, kind of a generic sheet. So to me, having a good patient flow, maximizing how you work with your computer, cross-training your employees, and then having a rhythm to your office is really important. And it all begins with a phone contact, scheduling that new patient for their first visit, getting the paperwork done, spending enough time that you really need to get good diagnostic information for that patient, address their chief complaint, and then organizing a specific sequence of treatment. And I think I do this totally different than I did when I was just a regular dentist, because as a biologic dentist, we're looking at so many more different things now with that patient. First thing I always think about, of course, is infection, periodontal, hard tissue, anything on an x-ray that might be close to the nerve or the pulp. We're going to talk to that patient about the possibility of a root canal or extraction. And any root canal that I see that's short of the apex, if I only see 2 gutta perches where I should see 3, if you see a little lesion above the top of a tooth, we're going to talk to that patient about doing topaz at least once a year and comparing that with a Meridian stress analysis to see if you got a bad stress on that tooth from your MSA test and you've got a positive topaz test, you really are obligated, I think, to talk to that patient about an extraction or at least a retreatment. Okay? We're looking at cavitations now a lot more, and I'm lucky enough to have Gary over in Tennessee to help us with those cavitations, looking for genetic congenital defects, looking around the gingival tissues to see if you see any green stain or any kind of incompatible restorations along with the mercury fillings. I also take oral pHs on all my kids to see if they're anywhere close to critical pH, because it's going to take a long time for them to buffer that saliva back to normal again. And then we're also going to look for Kaposi sarcoma in the roof of the mouth. You're going to look to see if the periodontal disease does not respond properly to treatment. Suggest a glucose tolerance test to the patient if their periodontal condition does not improve. after traditional therapy. And at the very end, we talk to them about bleaching, restoring their mouth back to function, doing some partials, dentures, stuff like that. So to me, this is like a little logical flow chart that I think about with every patient that walks in the door. Sometimes the doctor or the MSA test will say, well, the lower right quadrant is more stressed out than any of the others. If you're using a CERAC machine, it really doesn't make any difference because you're going to make the crown as soon as you prep the tooth. But if you're using a traditional lab fabricated crown like I do, I just get a better fit, I think. I do my crowns first, and then when I deliver the crowns, I'm going to do my other composites on the second visit. That way you don't have a third visit to worry about to re-anesthetize that patient. So this saves you a ton of time if you can think what's the right sequence to do this treatment. And we have patients traveling from all over to come see us, so I don't want them to make multiple trips if not necessary. A route slip, if your software will do a route slip, this will tell you all the allergies, proposed treatments, and also missed appointments. We do our scheduling, we do our Casey education, show the smoking tooth video, and then I'd like to email radiographs to other dentists and doctors if necessary. To me, this is the best way for me to load the monitor on the wall. The new ones are on the ceiling, but to me this is more convenient because you can do your scheduling off to the side. You can bring the x-ray over to the patient, show them if there's a problem with the tooth. We also set up an ideal day. We want to maximize benefits for the patients with their insurance. About once a quarter, I go over with my hygienist their production figures, and I really need for my hygienist to produce about 4 times their salary every quarter. So we review that with them. If they get a little bit behind, then we talk to them about pushing the perio, being more attentive to the pocket depths, doing some more alternative therapy. In North Carolina, hygienists can also do sealants. I don't know if it's that way where you guys all practice, but we do quite a bit of sealants on the kids. And then we use the computer to email information, and we also point to IAOMT website. EagleSoft has a particular program. I don't know if Dentrix and SoftDent have this, but you can put in what's called exploding code. When I find a patient that has mercury underneath the crown, we want to get that crown off, remove the mercury, and then glue it back on again. So the exploding code, as soon as you hit this on the computer, it brings up the mercury disposal fee, which was what we charge for the biologic technique. It brings up the re-cement crown fee, and then a core buildup. And this is tremendous when you're doing perio, because when I just type in X mod for moderate perio, it brings up the scaling, it brings up the oral hygiene instruction, it brings up the circular irrigation, it brings up every code that you would need to treat a periodontal patient, so it saves you a tremendous amount of time in doing your keystrokes. So if you can't read this, to me a good dental experience is kind of like going to your favorite restaurant. And at the bottom, if you can't read it, it says, George was undeterred by the threat of mad cow disease, and you can see what he's ordering for dinner. He's ordering beef brain and spinal cord tartare with a glass of Merlot. Again, I'm in western North Carolina in the mountains, and if you live in the mountains, you want to live at the beach, and if you live at the beach, you want to live in the mountains. So we have our office kind of decorated like a Hawaiian theme. And I want more of a theme like it's a hotel lobby as opposed to a clinical situation. But the advantage we have over a restaurant is we know our patients by name. The finances for the work is all prearranged. We offer a longer lasting product, which improves their quality of their life in the end run. And we also have longer lasting relationships. So sometimes I tell my girls I'm just like a short order cook. You just have to know where you're going to be every 10 minutes of the day. Keep things organized, keep things moving. So this is basically the order that I use in my head for diagnostic efficiency for doing our digital radiograph, pictures, computerized treatment planning, and the paper technology. So I went ahead and scanned a Meridian stress analysis for you guys to look at. This was a very mercury toxic patient. He had a lot of colored mucus that he was kicking up every day from his lungs. Dr. Colgate told us first get the mercury out, second extract his root canal, and then deal with the galvanic stress. She puts a little dot next to a tooth or a cavitation if she thinks there's stress in an area where there could be a cavitation. This was his root canal that had been giving him symptoms for about 3 years. So she really had recommended having that removed. And then I get about 3 pages of all the different dental materials that we use in our office. And she'll say, okay, this is the stuff you can use, this is the stuff that you might could use, and this is the stuff to avoid. Now the exception to that rule is if I can't get a patient numb, and I've tried Septicaine, I've tried Carbocaine, and I want to use Marcaine to get them really comfortable, if it's on the maybe or the not to use list, then I'll discuss that with the patient. It's more important for me to get you really numb This anesthetic's going to be out of your system in about 4 or 5 hours. You're going to have a lot less epinephrine and problems with you systemically. So occasionally I'll use some of the stuff that's on the not to use list, but only in a case like that. And then when I discuss it with the patient. So they have informed consent. They know that this is not on the good list, but we're going to use it anyway to get the job done. I shopped for digital panoramic machines for about 2 or 3 years, and I chose the Sirona. I had a neighbor that had the Plan Mecca machine, and he had replaced it 3 times. Sirona is a German company. They have their headquarters in Charlotte, which is just an hour down the road. So I got to go down there and play with all the new toys and check all that good stuff out. And the reason why I like this so much, it has a very small footprint. It has its own IP address on my network at the office. You can take a panoramic from my office in any room. I can even walk down to the employee lounge and put it on my laptop and take a panoramic from the employee lounge if I want to. There's no chemicals in my office anymore. There's no hazardous materials to deal with. And I can print off as many originals as I want to and email them and send them to orthodontist, or I send them to Gary for him to look at the cavitations for me all the time. So it's a really slick machine. You could also manipulate the image. This was me before I got my Mercury out. And yes, I do still have a root canal in my front tooth. This one was extracted. But this is a really neat machine because you can blow up on the software. It has a contrast window where you can get more contrast. So it's a pretty cool machine. For PAs, I chose the DEXIS system because it's an employee-owned company, number one. They have very good customer service. The probe is exactly halfway between a pedo and an adult probe. So it's a little bit more comfortable on adults than the other systems. The wire on the probe is on the back of the probe, so you get 100% of your image that comes up on your screen every time. All the other systems, the wire's off to the side a little bit, and you lose about 15% of your image. And this is called a DEX box. So the advantage of this system is you don't have to plug it into a computer. If you want to share this among 2 or 3 different operatories, you can have this in a passway between your operatories. You don't have to buy as many units. And then this little thing just plugs in and out, and you can walk from room to room to take your x-rays. So it's just a really slick setup. You can divide the x-rays chronologically. If you're doing a root canal and a post, you can take 3 x-rays in a row, and these literally come up as soon as you mash on the button. It comes right up. You can also have it set up like a traditional FMX with all 18 views. And the software is very intuitive. It knows you're going to use your rings, and you're going to go boom, 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 and then it's going to flip over to here, and you're going to do your lower side. You're going to flip your rings around and do the upper side, and then it cues you to do this lower left. So it knows exactly, as a real human being, how you take your FMX, and so it's very intuitive. You can import and export the films. It has, again, a magnifying glass and a contrast button. And one thing they came up with a couple years ago is they have every single implant made from every single manufacturer. So if you could get a reference length, you can cut and paste any implant that's made and put it in the hole to see if it's going to fit, which is pretty cool. What happens if your digital system goes, your hard drive dies on you, or your computer just dies? This Ergonomics is a really neat system, just like a Polaroid camera. You take the picture, you walk up to it, and you squeeze on this little bag, you peel the x-ray out, and you can take as many x-rays as you want without your digital system in case it dies on you. And they're on the web, ergonomics.com. I chose a system called DigitalDoc because, for several reasons. Number one, it's wireless. You don't have to have it attached to the patient if you've got a wheelchair patient. If you don't have to buy as many cameras. You can buy one camera and use it in any operatory you want. These work great for patient education if you have fractured amalgams, if you have galvanic stress around your amalgam. We take a full series of pictures and layer it on the DEXIS software with our photographs and the x-rays all at the same time. So in case the little red man stares at you after you take your DiCal app, and everybody knows who the little red man is, right? This is the time where you talk to the patient that you might need a root canal or an extraction with this tooth, because we did get into the pulp here. And then patients love to get the before and after. I tell them this is the refrigerator art to take home so they can appreciate getting all their mercury out. And so a lot of patients like to have this for their records too. It's just a really wonderful toy. And then I switched over from a 2-power to a 4-power because my eyes are getting tired now. And I did switch over from a halogen light to LED. These lights are guaranteed for 50,000 hours. It's not a $50 light bulb that you have to buy. And LED is just, it's the only way to go now, I think. So every time a halogen light bulb burns out in my office, I replace it with an LED now. Now it's time for the DVD.
In about 3 minutes here, we're going to treatment plan this complete patient, looking at all the different views. First, the panoramic shows us the upper right quadrant with impacted number 1, number 3 with a root canal, and 4 other mercury fillings. We'll look on the other side of the mouth and see 3 other mercury silver fillings on these left quadrants and other existing restorations, looking for periapical infection, anything unusual. The patient wants to get number 3 out because it's been bothering him ever since it was done, and he really wants to also talk about number 1. We're going to use the Dexis on the left, EagleSoft on the right. First, reviewing the bite wings from right to left. Then we're going to look at the individual tooth pictures and the patient's smile, the way the teeth fit together. First off, we'll treatment plan the left side. Tooth number 14, occlusal lingual, be a 2-surface composite, occlusal lingual. Then we're going to do tooth number 15 right next to it. Notice the little distal crack there. We'll probably go ahead and drill that out and fix that at the same time. Then we're going to number 19, occlusal buccal. We're also going to include a biologic technique fee, which is our fee that we charge for the oxygen to remove the mercury safely. That's going to be all appointment number 1. Then on the other side, we'll move to appointment number 2. Tooth number 2, be an occlusal composite. Moving on to tooth number 5, which has a very large amalgam filling. We're going to be doing a composite core and a lava crown on this tooth. So the computer allows us to very quickly put in the comp C, which is our code, and lava, which is the code for the crown. Next, we'll look at the lower right quadrant because the patient wants to do one side of his mouth at a time. So tooth number 30 and 31, they'll be fairly large occlusal buccal composites. And then we'll also add our biologic fee, which is the fee that we charge to remove the mercury again and dispose of it properly. We can also look at tooth number 3. This will be a tooth that the patient wants to get extracted and have another bridge put on that upper right side. So we'll simply put that in as appointment number 3 for the extraction. We want to take an x-ray of it afterwards to make sure that the surgery went successfully. Make a temporary bridge, allow that to heal. And then we'll do an anterior retainer, a ponic, and a posterior retainer so the patient will know what the total cost of his treatment is going to be. Again, we add the mercury removal for the other side, bring us up to full screen, review it, make sure the number's right, set it up to print. We put 1 copy in the chart and 1 copy for the patient to take home, and we're all done.
The rest of this is I'm going to go over pretty quickly now. Applying inventory is something that's become kind of a pet peeve of my assistant because she got tired of keeping track of about 40 different burrs. So my philosophy now is that a dentist who works with 100 different burrs will never be as efficient with one that can do with 10. I also think in terms of multi-use, if you can use your impression material for relining partials and do it for crown and bridge, try and throw away as much of the stuff that you don't use every year. And then, like I said, we have a throw-out day at the end of the year, and I tell my assistant, anything I haven't used in 12 months, throw it in the trash, because it just takes more time to do inventory. If you're a guy who keeps 100 burrs, and you're probably spending 20 or 30 bucks for some of these really expensive burrs, and there's so many choices now, it's just not worth keeping that much inventory. So the keys to clinical success is to make sure your front desk keeps things moving. All my front desk gals take blood pressure, seat and greet the patients. Make sure you use some synergism to get really comfortable, profound anesthesia. There's nothing worse than putting the rubber dam of the oxygen on and you start taking the mercury out, the patient goes, I feel that. So you have to really make sure you're getting good, comfortable anesthetic. Train your assistant to anticipate. Use each tool to its maximum and then move on to the next one. I check my hygienist randomly. In North Carolina, you do not have to wait till the hygienist is done. So I'll check her right in the middle of her procedure. And on 2 days during the week, I work with 2 different hygienists. We like to cross-train all the employees so they appreciate each other. And this last line was my hygienist's favorite of the presentation. Hygienists can suck spit too. So we work quickly and efficiently. We try and be concise and succinct with the patient. Their perception of what's going on is their reality. If you're always having to get up to go to the other room to pick something out from the supply room, you don't look organized. If you have everything right there and ready to go, their perception is that you can move smoothly from one phase to the next and not have to be interrupted. And I feel if you give patients too many choices with their treatment, that they suffer from choice paralysis. The next thing they say is, oh, let me go home and think about it. So I give them the choice. If they were a member of my family, this is what I would do. If you don't want to do anything, that's fine, but this is really the best choice. And I find that if you treat the apple farmer the same as the brain surgeon, you're much more successful. I'm really surprised the number of apple farmers who want to get their mercury out, and the number of MDs who just want to ignore the research. To me, that fascinates me. When you buy something new, make sure you check how much it's going to cost over time to own it. With the DEXIS system, every time you buy your insurance for your probe, you get your software update. You don't have to pay for that separately. And the insurance on one of these probes runs about $1,200 a year. So you really have to kind of go, when you cut that check. But if you drop the probe, you have another one in 24 hours from DEXIS. They'll FedEx you a new probe within 24 hours. They really stand behind their product. How much will it increase the quality, save me over time? What's our return on the investment? I used to have a crown and bridge tray, an endo tray, a root canal tray, and a composite tray. Now we just have a universal tray. And we can do everything off this one tray with my 10 burrs pretty much in the office. To me, the Continental design works better for four-handed dentistry and biologic technique because you never have to take your eyes off the patient while you're working. You can literally just reach out, grab a handpiece, let loose of it, and there's no turning of your body whatsoever. I like the larger oxygen tanks because they don't have to come so often to my office to change them. And then I have everything from my biologic technique pretty much within about a 12-inch diameter from where I'm working. I have all my biologic materials all set up within the first top 3 drawers. I keep all the computer equipment hidden from the patient's view. And we have this really neat pass-through cabinet so you can grab trays from either room. You don't have to walk around the hallway to get a tray. And that saves us a tremendous amount of time too. This is the latest thing we got last week. I just switched over to a 220-volt autoclave. This thing not only saves you electricity, but it saves you a tremendous amount of time. This thing gets hot in 7 minutes. It's an 8-minute cycle. And so I'm saving at least an hour on my sterilization every day using a 220-volt autoclave. So if anybody's ever thought about that, or if you're in the market for one, I definitely go with the 220. Ergonomics is important in my office, and we train the assistants to work really close with me with the four-handed dentistry because every time you go to a new classification of movement, you're having to put more stress on your body. You're having to rotate your body while you're working. And if the assistant has to reach all the way across the room for something, it slows you down tremendously. So we talk a little bit about working with the patient with really good posture, reduce stress on the back. Make sure you have linoleum or tile in your operatory and not carpet because carpet not only soaks up mercury, it puts a lot of stress on your lower back when you're having to scoot your chair across the room. Keep the instruments in your delivery system as close as possible. Keep your motions to a class 1 and class 2 as much as possible so you're not having to reach for anything, and then minimize the body rotations. And I notice a big difference in my lower back pain when I've got good posture during the day. You know, if you're standing up and pulling teeth and cutting out roots, and puts a lot of stress on your back. We also set up for templates with my time. We're prepared for any contingency. You might be doing an occlusal amalgam and have a whole cuss tip fall off the tube. And if you're not ready to do an inlay right then, if you have to retool and go grab another tray set up or go reach for impression material, again, it's going to slow you way down. Do some time studies on yourself if you already haven't done it to see how long it takes to do each procedure. Make sure you get exquisite anesthetic. And then every time we do something on a patient, we're telling them the benefit of using the rubber dam is we're keeping the mercury off your throat. The reason why we're using the oxygen is to keep you from breathing the mercury. So every time you're using something on that patient, you're communicating the benefit of using that particular product on the person. So now you can see with the Continental design, with the handpiece and the patient, this is all within about a 12-inch circle. So I'm not having to rotate my body at all during the procedure. We keep the air filter over here. And if you haven't noticed yet, I'm left-handed, so that's why everything's from this side. Again, developing a clinical rhythm, get the patient really comfortable, remove all the amalgam decay at the same time, redesign your preps if you have to change from a composite to an inlay, switching over to a single component adhesive. How many guys use single component adhesives in here now? It'll save you a tremendous amount of time. Whenever there's something unusual on a chart, I always have this admonition at the end. Does anybody know what this stands for? If you've taken the CNA risk assessment course with the insurance company, patient was given the opportunity to ask questions and have them answered. To me, this really kind of seals the deal if there's a question about whether or not the tooth needs root canal, if there was a question about what material was used, especially when you're doing surgery. Rubber dam versus cleanup. This is probably something we all talk about every day. I tried to clean up. I really just don't like it because if there's amalgam in an undercut cuss tip, you can't see it. You're constantly have to taking it off, putting it back on again. I prefer using Lumiblock in a really nice nitrile dam because I can get that thing sealed up where there's almost no mercury dust after it comes off. There's lots of cracks and recurrent decay, contaminated dical. We all know what we see underneath these amalgams when we take them off, and I just have much better luck with the Lumiblock. So we get the decay out, keep our preps designed as conservative as possible, look under those cuss tips for undercut amalgam because you know the old guys used to really cut those things hollow to get the amalgam to stick. Make sure you remove all your thin enamel margins and then continuously think in your brain while you're working, can I still do a composite? Do I need to move up to an inlay or an onlay? And we kind of leave some treatment plans open-ended in case we have to do that. To me, for you guys who aren't using this yet, single component adhesives really will save you a lot of time. You're not having to worry about over-etching or under-etching. And if you get those little white lines around the outside of your composite after you've trimmed it up, it's probably because you've over-etched. When that happens, you're taking too much protein from between the enamel rods. Then the enamel rods are very weak, and you go to polish your composite, and those enamel rods begin to fracture, and that's where those little white lines come around the side of your composites. There's less sensitivity because you don't have to etch the dentin. And to me, it's a more biocompatible material. There's several of these on the market now. Park Hill, I think, has done the lion's share of research on their not biocompatibility, but the bond strength. The activator is in the brush, and the fluid